Hi everyone. So today I'm going to talk about management of axilla in the center of biopsy era, radiation oncology perspective. There are various ways of doing the same thing, and I'll discuss the literature. And based on the literature, uh, I would also discuss what I do in practice. Again, that's not the only way of doing things, but that being said, this would be my perspective. So we all know that central for biopsy has become standard of care. The management of axilla has gone through a lot of transition in the last 15 to 20 years. When I started my residency, it used to be axial lymphodissection for all, but gradually sentinel for biopsy became standard of care for clinically node negative disease. But those who were node positive would undergo dissection. Then the clinical trial came out and showed that for one or two positive node, we don't need dissection. And expanding the indication for sentinel for biopsy now, those who have neoadjuvant chemotherapy and have complete imaging response, they can undergo sentinel for biopsy. And if they are negative, then that ends the management of the axilla from surgical perspective. But if they're positive, they still undergo dissection, although that is also evolving with the recently completed Alliance trial. So this is why sentinel biopsy became standard of care. And these studies also defined the volume of disease, which define what to do. Like ITC considered like a node negative disease, micromets from 0.2 to 2 millimeter and macromets more than 2 millimeter. These four prospective randomized trials showed that in women who undergo central biopsy versus lymphodissection, there is no difference in yield as well as disease-free survival, but there is significant high risk of lymphedema and shoulder dysfunction and numbness when you undergo lymphodissection. So because of this, central lymph biopsy became standard of care for node-negative breast cancer. Now, once it became standard of care for node-negative breast cancer, the idea was what to do for node-positive disease. And the ACISOG, MROs, IBCSG, ARTRAM, and I'll discuss some of the other trials, which basically define uh, the outcome of patient with 1 to 2 positive node without undergoing dissection. So these are four prospective randomized trials which compared axial lymphodissection versus central for biopsy with no additional radiation field for women who undergo lumpectomy predominantly and have micromets, macromets, or both. The IBCSG and the ATRAM were basically for women with micromets and lumpectomy, and they showed that the risk of additional disease was 13%, but there was no difference in exit recurrence in, in women who underwent lumpectomy and radiation therapy as part of the care. In IBCSG, about 20% of the patient had mastectomy and didn't have anything to the axilla, but there is no difference in exit recurrence rate. The ACISOG caused the adoption of this option for women with lumpectomy and radiation when in women with micro or macromets, one or two positive node, the risk of additional disease was about 27%, but there is no difference in exit recurrence rate. And with the 10 years follow-up, there is no difference in disease-free survival. And I'll discuss some of the pitfalls of ACISOG Z11 in terms of volume. More recently, the Synodar 1 came out with similar size as ACISOG Z11. Majority of women had lumpectomy done, but 25% had mastectomy without radiation. The major difference in Synodar 1 compared to the other study was it only allowed macromets, where the risk of additional disease was about 44%. But again, if you look at recurrence rate, no difference in exit recurrence rate. With 3 years follow-up, no difference in disease-free survival. So these all four studies with predominantly lumpectomy with some mastectomy show that when they get lumpectomy plus radiation for micromets or macromets for one or two positive node, dissection doesn't add to axillary control rate or disease-free survival, and but there is more risk of lymphedema and more risk of complications. And around this, like Z11, the biggest the criticism is the volume of treatment was not defined. And when they retrospectively went back and looked at some of the volume of treatment based on physician-reported volume, they got RT field for about 228 patients. 81% had tangent only, and 53 out of about 50% had high tangent, treating level 1 and level 2, and about 19% had third field added, especially when they had high nodal involvement. They didn't see any difference in recurrence rate based on what volume was treated, but there is a lot of bias in terms of selecting what volume to treat in what subset. So that confounded the practicing physician to figure out what to do in these women who do not undergo dissection. So this is an example of whole breast radiation therapy. You can see when you do whole breast, part of the low-lying 1 and 2 gets treated, which is the area of highest volume disease. When you do high tangent, you intentionally increase the tangent upper border, and you can see on your right that you are treating much more level 1 and level 2 than what you treat when you do whole breast, where you get incidental dose of radiation therapy. This is again whole breast with part of the axilla getting treated. Now, the first slide I showed was for 1 or 2 positive node with no additional field. The second one I showed was with additional field. And this was the study which basically looked at comprehensive regional radiation therapy in lieu of lymphodissection. I will only focus on the top 2 study because they were done in the Central of ERA. The French study was done with dissection. So the EMERALD trial it's one of the largest clinical trial in this setting with about 1,400 patients. They allowed both micromets and macromets. The risk of additional disease was about 33%, very similar to Z11. The follow-up was about 10 years follow-up has been reported. No difference in axillary recurrence, no difference in disease-free survival, but as expected, about 2-fold increase in the risk of lymphedema if they underwent dissection. The OTO-SR trial, which is the recently reported study, smaller study, looking at similar philosophy like EMERALD, about 474 patients. The risk of additional disease is about 38.5%, with 97 months median follow-up. No difference in the recurrence rate, no difference in disease-free survival, but as expected, significant difference in lymphedema. So if you look at summary of all these 6 clinical trials for patients with 1 or 2 positive lymph node, whether micromets, macromets, or both, there is risk of additional disease, which varies from 13% to almost 45%. But lymph node dissection doesn't improve axillary recurrence rate or disease-free survival, but does cause increased lymphedema. But the variable in all these studies, if you combine together, is what volume to treat, whether it is whole breast, high tangent, or comprehensive 3-field, and what is the optimal for the patient. It's still probably not known, and that's why there is a lot of variation in the practice. So this is like for micromets and mastectomy, like with all the studies we talked about were predominantly micromets with lumpectomy. But in a subset of patient in IBCSG and ATRAM had mastectomy done, and they did not have lymphodissection or radiation therapy. And they had very low recurrence rate, but these were low risk disease, predominantly T1 disease, ER positive disease. So in patients who undergo mastectomy with central biopsy without complete dissection, can we safely omit post-mastectomy radiation therapy? Unfortunately, this has not been answered in the randomized trial, and I will discuss some retrospective study in this setting. So this is the largest retrospective study from MSK, where patients with T1, T2, ITC or N1 mic treated with mastectomy. So about 211 had ITC and about 141 had micromets. So 46% had only central biopsy done, and one node was positive in about 84% of the cases. So at a median follow-up of 6 years, the crude loco-regional relapse was about 2.8% with no axillary recurrence rate in patients whether they had lymphodissection done or not, with the crude loco-regional recurrence rate of 3.9% among those who had central biopsy done. No difference was found between loco-regional relapse and received post-mastectomy radiation therapy, lymph node biopsy versus lymphodissection, or number of positive nodes. So the authors concluded that local regional recurrence rate was infrequent among T1, T2, N1 mic or N1 ITC who undergo mastectomy without PMRT, suggesting that PMRT or nodal radiation therapy or low node dissection is not routinely indicated in these patients. What about in patients who have the macromets? So generally, but there is is PMRT indicated in T1, T2 disease with positive central biopsy, especially if they have macromets. So if you look at the ASTRO guideline, the ASTRO panel recognized that some clinician may omit lymphodissection for 1 or 2 positive node in patient treated with mastectomy. So the panel recommended that in these patients, if there is enough indication to recommend post-mastectomy radiation therapy, like high-grade disease, T2, premenopausal, triple negative, high oncotype, then we can omit dissection and move on to radiation therapy because they benefit from post-mastectomy radiation therapy. Axilla can be addressed with post-mastectomy radiation therapy, so less risk of lymphedema, and they have double benefit of avoiding dissection and also the benefit of post-mastectomy radiation therapy. But for those who do not meet the criteria, it's debatable, and you have to discuss pros and cons of radiation versus dissection. So for patients with central biopsy and one or two positive nodes don't need external lymph dissection as the risk of regional recurrence is low with and without lymph node dissection. The volume of nodal radiation therapy is variable from none to tangent RT to comprehensive regional nodal radiation therapy with similar outcome. And again, whether they have lumpectomy or mastectomy, the principle varies. But that being said, in the conglomeration of all the studies, variable volume has been treated with no difference in regional recurrence rate, no difference in disease survival. But there is a bias in who gets what in terms of management. What about if they undergo neoadjuvant chemotherapy? So now, because of AKISOC 1011, Sentina, and B51, in patients who are clinically node positive with N1 disease and the node normalizes after chemotherapy, they undergo centrifugal biopsy alone. And if the negative predictive value of centrifugal biopsy was variable in those studies, but I'll discuss the pros and cons of it. But if the node is positive after neoadjuvant chemotherapy, they undergo dissection. And that's also being studied as part of completed alliance trial. So if you look at the false negative rate after neoadjuvant chemotherapy when node normalizes, in the clinical trial, both Sentina and AKISOC 1071, the false negative rate was more than 10%, which was above the threshold defined in the study. So the study, the way they were designed, were negative study. But when they went back and looked at in patients who had 3 or more node taken out or had dual tracer, the false negative rate was less than 10%. And the additional technique employed is marking the needle with the clip and making sure that positive node is taken out with the clip or at the time of centrifugal biopsy. And when you do that, then you can decrease the false negative rate. So in women who undergo centrifugal biopsy, if more than 2 nodes are taken out, dual tracer is used, and the clip node is taken out, the false negative rate is low. And it's accepted in practice now to undergo centrifugal biopsy if the node has come back as negative. So what do we do in terms of management of this patient? If they're clinically N1 and they become pathologically N0, the value of regional nodal radiation therapy is debatable, and it will be answered by the completed B51 study. If they are clinically N1 and they persist to be pathologically N1, they all need axial lymph dissection followed by regional nodal radiation therapy. Although ongoing alliance trial is looking at lymph dissection plus radiation versus RT alone. But if they're clinically N2, then irrespective of the response, they all need regional nodal radiation therapy. The B51, which is the clinical trial for node positive who become node negative. And if they have lumpectomy done, then they are randomized to whole breast with and without regional node. If they have mastectomy done, then they are randomized to with and without post-mastectomy radiation. The alliance trial, if they have persistent node positive disease, then they are randomized to dissection followed by radiation versus radiation alone. Important thing to realize is that ITC after neoadjuvant chemotherapy is considered to be node negative, so was allowed in B51, but was not allowed in alliance trial because they were considered node negative after chemotherapy. This is the retrospective study from our own institution looking at 161 patients who had centrifugal biopsy done after neoadjuvant chemotherapy. Some had dissection, others did not have dissection. We did not find any difference in regional recurrence rate, 92.6 versus 96.4. Regional recurrence rate as part of first recurrence occurred in about 5.6%, but extent of nodal dissection did not predict. So a patient who underwent lymph node dissection had more lymphedema as expected, but you have to understand it's a retrospective study. Most of the patients who were treated with radiation therapy in lieu of surgery had low volume disease. So we cannot be conclusive in that aspect. But that being said, if women decline surgery, then there are some data to suggest what may happen. So carefully selected radiation in lieu of axial lymph dissection is an option, but we need more data. The recently reported RAPCHEM book study in Lancet Oncology. They had 171 patients with high-risk disease, and they defined high-risk with either pathological N2, N3 with lymphodissection, or they had central for biopsy done with persistent positive node, or N1 mic with LVSI grade 3 or T2 and above disease. So they did allow central for biopsy alone, even after neoadjuvant chemotherapy, in that prospective database of women who underwent neoadjuvant chemotherapy. When you go into the detail, you find 24 patients, so 14% had central for biopsy with no axillary dissection for node positive disease after neoadjuvant chemotherapy, which is this subset or this subset. And they did regional nodal radiation therapy to level 1, 2, 3 in supraclav, and IMN was optional. The local regional recurrence rate for that subset was 2.3%, but they did notice that if radiation guideline was not followed, the risk of recurrence was higher. There is no difference in local regional relapse with dissection versus central for biopsy, but as expected, the disease-free survival was better, probably because of reflecting low volume disease. So that being said, even though it's part of the complete alliance trial, in practice that's happening, that women do undergo central for biopsy without dissection for persistent node positive disease for both macromets or micromets. The small subset of patients, you cannot conclude much about it, but at least there is no increase in local regional relapse if comprehensive nodal radiation therapy is done. So what about ITC after neoadjuvant chemotherapy? That's an area where there is limited data and probably controversial, because by true definition, ITC is node negative. But is ITC after neoadjuvant chemotherapy same as upfront ITC? So if you look at the MSK data of low volume disease, like the 711 patient who had central for biopsy after neoadjuvant chemotherapy, about 59% had micromets and 63% had macromets, and had more than one node positive at lymphodissection. But there was a subset of patients where the frozen was negative, so they did not have dissection done. And overall, when they looked at what was the outcome in patients who didn't have dissection done, or who had, what was the risk of additional disease in patients who had ITC or micromets, and you can see for ITC, 1 out of 6 patients had additional disease, and for micromets, 64% additional disease, which is much more higher than what you see in ITC and micromets in upfront setting. Similarly, there is an FNA study where they looked at what is the risk of finding additional disease for ITC, and the risk was almost like more than 30%. So ITC post neoadjuvant chemotherapy is not the same, and even though considered node negative, without dissection, their risk of additional disease is much higher than what we see in upfront setting. And I, in my own practice, treat like a persistent positive disease with comprehensive regional node radiation therapy. Now, a brief overview on regional nodal radiation therapy. Like we all know that the MA20, the EORTC, and the Danish data, and now recently the Korean data, caused the resurrection of regional nodal radiation therapy, which means treatment of undissected axilla, supraclav, plus minus IM node. This is what the regional nodal radiation therapy means, like undissected axilla, which could be 1, 2, 3 supraclav and IM in patient with central for biopsy done. So in MA20 was after lumpectomy, most were node positive, and IM nodal was treated to first 3 intercostal space. If you look at, there is small difference in regional recurrence rate, 2.5 versus 0.5, but similar difference in disease-free survival and overall survival. If you can look at about 4% improvement distant recurrence and 5% disease-free survival. So when you look at Oxford meta-analysis, which talked about 4:1 ratio, for each 4% difference in local regional relapse, there is 1% improvement in breast cancer mortality. This is being challenged by the MA20 and EORTC. The difference in regional recurrence rate is very small, 2.5 versus 0.5, but that translates into distant recurrence and disease-free survival, and that's what is more important endpoint, probably showing that not all nodal disease manifests itself as regional recurrence, and the idea of treating the regional node is to decrease the risk of micrometastatic distant mets, which is more important endpoint. Similarly, I mean, there is small increase in pneumonitis and radiation dermatitis, but it was significant statistically, but still on the spectrum of mainly grade 1 and grade 2 morbidity. Similarly, if you look at EORTC, which allowed mastectomy also, and they had stage 1, stage 3 breast cancer, they had more node negative than the MA20, about 44% per N0, and about 76% had lumpectomy and 24% mastectomy. The randomization was similar with and without regional node. They treated first 3 intercostal space like MA20, but they allowed 5 intercostal space if it was lower quadrant disease. But again, if you look at the difference in local regional relapse, 4.2 versus 2.7, very similar scale as MA20. But again, look at distant mets difference look at disease-free survival and breast cancer mortality. So both MA20 and EORTC shows one thing, that we cannot use regional recurrence rate number from retrospective data to show the value of regional node, because it's not necessarily the regional node recurrence rate which matters. It's the risk of distant mets and overall survival matters. And it's hard to see that difference in a small retrospective analysis. And when people report low local regional recurrence in the modern era, which is true, which was seen in these two clinical trials also, but that low local regional recurrence difference did translate into breast cancer mortality and disease-free survival, and not overall survival as the extended follow-up. The Danish study was not a randomized study, but a prospective population-based study, where right-sided breast cancer got IMN and left-sided breast cancer got no IMN treatment. Regional node was on both sides, and they treated first 4 intercostal space, unlike the MA20 and the EORTC. And this study, they reported recently 15 years follow-up, and there continues to be difference in breast cancer mortality and overall survival. So it was more pronounced in high-risk patients with medial and central location 4+ positive node, and trend towards benefit in 1 to 3 positive node. It's not a randomization. There could be bias in right versus left side, but that's the best they could do. But even at 15 years follow-up, there is difference in outcome, suggesting that there is value of adding IMN treatment, especially for medial or central quadrant disease or large axillary burden disease, where you have a higher likelihood of finding microscopic disease in the IMN, and treating them may improve distant mets and breast cancer mortality. The most recently Korean study was only randomizing to with and without IMN. They were very overzealous in designing the clinical trial for 10% improvement in DFS, which is very hard to see just because of the fact that the entire regional node in EORTC and MA20 improved disease-free survival by 3 to 5%. So we don't expect IMN it by itself to make that kind of difference. So the study, the way it was designed, was negative, but an unplanned subset analysis showed that in those with medial or central located disease, there was 10% improvement in DFS. Again, suggesting that there may be higher value in large nodal burden or central or inner quadrant disease because of higher likelihood of having IMN disease. And if you look at this study, even though the study was negative, but the difference in DFS was very similar to the EORTC and MA20, but the power of the study was not there to detect this difference. Now, the quality of regional node does matter. Like when we looked at our own network, that the regional nodal radiation therapy only improves disease-free survival by 3 to 5%. In clinical trial, there is quality assurance for volume and the dosimetry, but in clinical practice, that may or may not happen. So when we audited our network to see what is the quality of regional nodal radiation therapy and whether that meets the criteria of having for contouring and for dosimetry and for volume, and what we found that some of the examples of the patient where the nodal radiation therapy included muscle and excluded the vessel, or you can see included the ribs and the intercostal but missing level 1 node in patients with undissected axilla. And what we found that treated nodes were not contoured about 2.2%, and lymph node were contoured were unacceptable in about 15%. Of patients receiving regional nodal radiation therapy, 15% did not have adequate nodal target contour. The mean heart dose was more or less acceptable, with a small number of people having heart dose more than 4 gray. And the V20 for the lung was exceeding in only a small percentage of people. So adherent to indication for regional nodal radiation therapy was high, but nodes were either not contoured or had unacceptable contour quality in 18% of the plan, and coverage was inadequate in 15%. So for us to translate that 3 to 5% difference in disease-free survival in clinical practice, we need to make sure our contouring and dosimetry and indications are appropriate for us to get the benefit. So what do we do in practice? In patients who have centrifugal biopsy done, has micromets, and have lumpectomy done and no dissection, we do whole breast radiation therapy, and I tend to include height level 1 or 2 in my tangential beam if they're getting whole breast. But if they are getting only whole breast alone, or PBI is also a reasonable alternative, because we have not shown that treating the axilla make a difference. So either of the 2 is a reasonable alternative. I tend to do whole breast with high tangent, but that being said, whole breast alone or partial breast is a reasonable alternative. If they have mastectomy done and have micromets and no dissection, for most of the patients I don't treat unless they are triple negative or they have multitude adverse factor like T2, LVSI, 2 nodes with possible microscopic ECE, where the risk of additional disease may be high that I may tend to treat. But for most of the patient after T1, T2 mastectomy, send for biopsy and micromets, I don't treat. If they have macromets, 1 or 2 positive and have lumpectomy done and no dissection, I at minimum treat whole breast with high tangents with level 1 and 2. If they have adverse factor like young age, ECE, aggressive phenotype, LVSI, high genomic score, then I do tend to add regional node, which include 1, 2, 3, supraclav plus minus IMN. If they have mastectomy with adverse factor with any one of these adverse factor, then I would add regional node dissection and do PMRT with regional node. But if they don't have adverse risk factor, then you discuss pros and cons of high lymphedema from axial lymphodissection or potential impact of reconstruction on the women who have had reconstruction. So it's an informed decision based on patient's perceived risk of either of the two and what is more important to the patient. MA39 is a randomized trial which is looking at regional radiation therapy for low volume node positive disease using Oncotype DX. If they have 3 or more positive node, usually they undergo dissection followed by radiation therapy, which includes regional node. If they have neoadjuvant chemotherapy and have their micromets or macromets, they undergo dissection followed by comprehensive regional radiation therapy. If patient declines lymphodissection, then we do comprehensive regional radiation therapy. We do go back and look at imaging to make sure there is no initially involved node which has not been dissected. If that's the case, then you tend to boost that node just to be on the safer side. If they have ITC only after neoadjuvant chemotherapy, then they don't undergo dissection. We do comprehensive regional node without any dissection. It is important that in your own practice you standardize what volume you would treat for what scenario, whether it is ITC, micromets, macromets, before chemotherapy or following chemotherapy. We did design a clinical pathway in our own network, and we did notice that after implementing the changes in the clinical pathway through consensus, the utilization and the standardization of regional node went up, including higher use of high tangent, higher use of third field for adverse factor. So it did help us standardize the care where there's consistency in the treatment protocol most of the time, not all the time because there are always variation, but it did help us standardize and probably look at outcome data at some point to see how it works. The radiation technique when you're treating is partial white tangent or photon electron match or IMRT or VMAT for regional node. I tend to use DIVH for both left and right sided breast cancer when I'm doing regional node because it helps decrease both heart and lung dose. And in the era when the patients are getting immunotherapy, TDM1 post neoadjuvant chemotherapy, whatever dose I can do to reduce the dose to the lung, I think it helps out. So I tend to use deep inspiration breath hold for both left and right sided breast cancer, especially when doing regional nodes. This is partial white tangent. This is matching photon electron with feathering every 1/3 or halfway through. And an example of IMRT. This is deep inspiration breath hold. What about fractionation when you do regional node? Hypofractionation is a standard of care. 40 grain 15 fraction is standard of care for us when we do whole breast based on START A, B, Wheeler in Denmark and Chinese randomized trial. Similar local region relapse, possibly less acute and chronic effect. If we do boost, we do 4 to 5 fraction boost in sequential in high risk, meaning younger patient, high phenotype, high oncotype DX, or patient who have neoadjuvant chemotherapy. We tend to do 10 grain 4 to 5 fractions. Recently, we have started doing some import high RTOG also, where we give SIB 14-15 to the whole breast and 48-15 to SIB. I tend to follow import high volume, which is surgical bed with 5 mm margin, unlike RTOG, which had larger volume for the boost. And since the outcome looks similar, to decrease the volume of treatment, I tend to follow import high. We also do 26-5 whole breast for patients who are postmenopausal with early stage breast cancer who don't need boost. There is an ongoing study which is looking at SIB boost with a shortened course, but I don't tend to use it outside clinical trial. For regional node, these are the 4 prospective randomized prospective study with some randomization in Chinese, Danish, and hypogeology study. They randomized to 15, 25 to 14, 15. The Chinese trial used a slightly higher dose, 43.5 and 15. So if you look at it, there was no difference in local regional relapse in either of the 4 studies, no difference in disease-free survival, and no difference in shoulder stiffness or lymphedema. So I tend to use hypofractionation for regional node based on these 4 prospective studies. The last 2 ones were presented at ESTRO. The Danish one is about 1,200 patients and the hypoG is about 1,100 patients. And they were looking at chronic effect, which was either shoulder stiffness or lymphedema. So 14 and 15 have shown similar efficacy. So I tend to use that for regional node, except in inflammatory breast cancer. Sometimes for patients with poor response to neoadjuvant chemotherapy where I want to give higher dose, or they have significant residual undissected nodal disease in IMN or axilla where I tend to give higher dose. Those are uncommon scenario. For most common scenario, we do 14, 15. We don't do 5 fraction fast forward and RNI. Even though 3 years data has been reported, we are waiting for the outcome data. So this is the dosimetry and toxicity in our own data set using hypofraction and regional nodal radiation therapy. We had 200 patients. Our median, the risk of grade 3 pneumonitis was close to 0. And our V20 was less than 26% in most of these patients who had hypofractionated course of radiation therapy. So we concluded V20 less than 26% is safe to limit symptomatic pneumonitis. That doesn't mean it's an upper limit. There could be a limit more than that. But since in our data set, that was what most patients got, either 26 or below, and only 1 patient had grade 2 pneumonitis, we tend to follow this if we can in terms of limiting the dose in hypofractionation to the lung. And now the field is heading in one other direction. So all the data I presented was for patients who underwent central for biopsy. But recently, the SOUND randomized clinical trial published their 5 years data of the primary endpoint of distant disease-free survival in women with T1 disease who were randomized to central for biopsy versus none. They all had a lumpectomy done. So most of them had whole breast radiation therapy. Like about 98 to 99% had breast conserving therapy, getting whole breast. Only 10% had IORT, which was either as a boost or as a sole modality. The median tumor size was 1.1 centimeter. Almost 90% were ER positive. The additional was the risk of central for biopsy positive was 13.7% because they were very vigilant in terms of doing the ultrasound prior to the surgery, and any suspicious node was biopsied, so which was more than what we do in normal practice. So this was the reason why the positive rate of axilla was much lower than what you otherwise see in other center for biopsy studies, but no difference in axillary recurrences or disease-free survival. A total of 12 local regional relapses were reported, and the risk of regional recurrence rate was very low. So in this randomized clinical trial, omission of central for biopsy was non-inferior to central for biopsy in patients with small breast cancer who had negative axilla on ultrasonography. So if this get adopted in your practice by the surgeon, then at this point I would probably offer whole breast radiation therapy to these women, except if they meet the criteria of Choose Wisely campaign for 70 and above, but I'm comfortable doing partial breast. But we still need to understand what volume to treat. But that being said, this is another direction in de-escalation of therapy for breast cancer, where we are omitting central for biopsy to even decrease the small risk of lymphedema or neuropathy. Some of the ongoing studies which are also looking at the same is the INSEMA is similar to the SOUND trial, but expand to T2 disease also. And the early quality of life data was reported at the San Antonio, but no outcome data. The POSNAC is for macromets, looking at something to do with the axilla versus none. That means to see whether systemic therapy by itself can take care of it without any additional axillary treatment. And Senoma, again, similar thing for macromets. So these will further define what we do with macromets. But currently, as I've said, for macromets, we always treat the axilla some way or the other, just because of the fact that data on not doing anything to the axilla is limited in mastectomy setting. So this, in sum up, concludes what I do in practice for patients with center for biopsy. This is not the only way of doing it. This is my take on the literature and my own practice pattern. And this is not absolute. It does vary in extreme situation. But that being said, gives me a consistent way of managing this patient. Thank you for listening. Thank you.